very much for the invitation. As Dr. Abad said, I work in Sevilla in the southern part of Spain, and I'm a consultant for Olympic teams and some of our professional teams in the city and in the country. So let's narrow the question. It's the we're going to be talking about mild idiopathic OA. That means that we won't be talking about traumatic OA, and we will not be talking about malalignment. In terms of what is the gap, we're going to be talking about the gap. But the gap is between prevention and classic treatments and the surgical treatment. So we won't be talking about controlling the risk factors, obesity and so on, and we won't be talking about the classical treatments, as well as we won't be talking about high tibial osteotomy, unicondylar, or a total knee arthroplasty. So how we will solve the gap? We'll try to solve the gap by building bridges. Is there a gap? Otherwise, I wouldn't be here. So yes, there is a gap, and 70% of the surgeons perceive it. Who falls in the gap? More or less 50% of patients who have OA, and that means 18 million of Americans, which is 3.6 million in the very gap, and that may last around 20 years, and it really costs a lot of money. So 3.6 million people are in the gap, and it may last at least 20 years. So whoever solves this question will be able to bridge a nice bridge and win the Nobel Prize. So let's see how should we treat it. Treatment golden rule is treat the cause. So you need to know what is causing OA and treat the pathophysiology, as well as treating the consequence, which patients come to the clinic because they have pain and dysfunction. They don't ask us to treat their pathophysiology. And also we need to know about the patient expectation and satisfy those expectations. So let's see, we will be sitting down here if we could solve all those in one only treatment. So let's see the physiopathology. If you look at here, we know that everything is involved in OA, synovium, cartilage, and bone. And what happens is they all get impaired, and that's why we need to go farther and try to understand what's going on. So there's a lot of molecules that would create a cartilage breakdown, and that, if we go to the molecular level, which as being orthopedic surgeons, we should be familiar with it if we're going to be treating OA. You need to be familiar with more or less metalloproteinases, interleukins, and growth factors. So what are the patient expectations? They expect us to relieve and reduce their pain, and they expect us to improve their knee function. And that doesn't change between developed or non-developed countries. So it means that they have high expectations and may create frustration for both surgeons and patients. And are we dealing with the aging natural process? Well, if we could be treating aging, that could be probably the solution for everything. And that has been done with anti-aging therapies, with testosterone and growth hormone. So if I could be the one treating aging, that probably I'll be the one getting the Nobel Prize. So what is the armamentarium that we have? These are all the types of bridges that we have in Seville, and I will try to bridge the gap of Rio Guadalquivir. So this is a classical bridge that we have in the city, and it's a copy of one that was in France. And it's like corticoids and anesthetics. It might be overutilized mainly to beliefs. So let's go farther, and we see that anesthetics and corticoids, they treat the consequence and not the cause. They take pain away really fast. They last around 3 months in average. And are they harmful? Well, the summary is that if you're going to use it, you should use ropivacaine or bupivacaine, and you should use triamcinolone and not betamethasone. And why? Because there's a direct injury pathway and an indirect to impair chondrocytes and synoviocytes by metalloproteinase. So lidocaine, it's chondrotoxic, not only by affecting the mitochondrial dysfunction, but also because in the presence of the synovial fluid, it's worse. And in the presence of epinephrine, it's even worse. So it creates more cell death. And why is that? Because it decreases the pH, and also because of the preservatives that are in the epinephrine. So if you're going to use any kind of local anesthetic, don't use it with epinephrine. And there's also an indirect pathway, as I said, with metalloproteinases in the role. What about corticoids? Well, don't use betamethasone because it's the one that creates more cell death. And why is that? Because it has preservatives that are also in toilet cleaners, and it also has a crystal structure. And if you combine lidocaine and corticoids, see, there is an increase in cell death, and mainly with betamethasone. So don't use that one. This is the bridge of El Alamillo, which it looks modern, but in fact, it's not that modern. It's been there since 1992. Like PRPs have been since 2002. So that opens up a new pathway that gives us another perspective of the city. So PRP are plasma and platelet proteins. They treat the cause and modify the inflammatory environment, angiogenesis, and extracellular matrix. It takes time to begin their effect, and they need multiple injections, at least 3. So there are many different products in the market. At least 17 have been described, and they all are different depending on their quantity, quality, activation, and timing. So we all know that it's better than hyaluronic acid and lasts longer. And since we published our paper in 2010, it's been the third most cited paper in the Journal of Arthroscopy. So there's an increasing interest in plasma proteins. How it works not only with growth factors, with cytokines and other proteins, and they work in the cartilage and bone, they work in vascular, and they work also in the synovium. So we're trying to treat physiopathology. This is the bridge of Delicias, which is nice, and it opens up a new door for other treatments like second-generation PRPs. And what it gives us is even a higher perspective of the city. So second-generation proteins, they target the inflammatory process by doing what? By increasing the anti-inflammatory interleukins and decreasing the inflammatory cytokines, and also has the growth factors effect that PRP had. How do we do that? Well, we improve the process by using polyacrylamide beads to adhere the non-desirable proteins and get the desirable proteins to be able to be injected in the joint and have their effect, paracrine effect on the joint. And these are the results that we can get in animals by improving cartilage, and also in human being by improving the bone bruise and cartilage. So this is the Quinto Centenario Bridge, and it looks like an American bridge, like the Golden Gate Bridge. So let's see how the Americans try to build up the bridges to solve the gap. There's a new thought on bone bruises or microfractures on the bone, and the subchondral bone, it's the cause of the problem. So there are novel techniques using subchondroplastic with biologic cements or PRP intraosseous to improve the results of subchondral. And this is a professional soccer player, and see how it creates more cartilage. So let's think a little bit out of the box. Let's try to not to use a bridge, but try to fly over the river and over Seville. How do we do that? Well, there's oral PRP now in the market, and it's allogenic. It comes from baby pork, so it has better quality of proteins. It's continuous addition of cytokines, so you can give it once daily. You don't have to inject the patient. They are always in the same concentration, and as you know, there is age and individual variability on PRP. And does it work? Well, we haven't used it in OA, but we have used it in a model and a multicentric randomized study in ACL, and we have seen that it optimizes healing and maturation of the graft. So finally, this is Pasarela San Jerónimo. It's a pedestrian bridge that doesn't allow traffic. So for us, this is one of the most important things, non-impact sports. But we know that people are usually non-compliant with these treatments, and it's better to do in a teamwork as well as in the clinic. And that would allow you to get a golden medal in the Olympics. So this is our approach. We try to approach with physical trainers, with doctors, with physiotherapists, and a team approach is desirable. And this is my team at home. Thank you very much for your attention.